Good afternoon, and welcome to today's special topic webinar, Nuclear Cardiology Lab Modernization and Novel Applications. My name is Nancy Davis, and I am the Director of CT Accreditation at the IAC. At this time, we would like to launch our poll question to get to know our audience today. Which of the following best describes the type of department you currently work in? Outpatient radiology, outpatient cardiology, hospital, or another type of facility? And we will give you everyone a few moments to answer. Thank you for your answers. And now I would like to introduce today's guest presenters, Dr. Renee Bullock-Palmer and Dr. Jamieson Bourque. Dr. Bullock-Palmer is a cardiologist and board certified in cardiovascular disease, nuclear cardiology, adult congenital heart disease, cardiovascular computed tomography, adult echocardiography, and internal medicine. She is currently the Director of Non-Invasive Cardiac Imaging and the Director of the Women's Heart Center at Deborah Heart and Lung Center in Browns Mills, New Jersey. Dr. Bullock-Palmer is on the board of the Southern New Jersey American Heart Association and on the FASNC Board of Directors. Dr. Bullock-Palmer serves on the IAC-CT Board of Directors as well as a representative from the American Society of Nuclear Cardiology. Dr. Bourque is the Medical Director of Nuclear Cardiology at the University of Virginia, where he is an Associate Professor of Medicine and Radiology. He also serves as Medical Director of Cardiology at the Novant UVA Culpeper Health System. Dr. Bourque has led research in advanced cardiovascular imaging, including SPECT and PET, myocardial perfusion imaging, and cardiac MRI for the identification and management of ischemic heart disease. Dr. Bourque serves on the IAC Nuclear PET Board of Directors as a cardiology member at large. We are thrilled to have these experts with us today. With that said, I will now turn this webinar over to today's first speaker, Dr. Renee Bullock-Palmer.
Hello, everyone. I'd like to thank the IAC and Nancy and her team for allowing me to plan and participate in this wonderful program today. So today I'll be speaking on nuclear myocardial perfusion imaging, the latest available technology to improve test accuracy and implications on lab accreditation. I have no disclosures. So I'll first start off with discussing the landscape of coronary artery disease and myocardial perfusion imaging in the US, as well as MPI testing in the US globally, as well as in the US, and also looking at the diagnostic landscape with regards to ischemic heart disease. And we'll run through some limitations of SPECT, the advantages of PET over SPECT, and we'll discuss a little bit on myocardial flow reserve, and then the future of nuclear medicine relative to lab accreditation. So globally, 73% of fatal coronary thrombosis is due to plaque rupture. Features of ruptured plaques include a large necrotic core, a thin fibrous cap, and expansive vessel remodeling, as well as spotty calcification and neovascularization of the vasa vasorum, resulting in plaque hemorrhage. Older studies have shown that the presence of non-obstructive CAD is most frequently found in individuals prior to their acute myocardial infarction, and there are more contemporary studies such as the ICONIC study, the PROMISE study, and the SCOT Heart trials that has shown similar findings that acute coronary syndrome occurs in previously documented mild stenosis, and in fact, high-risk plaque features show such as low Hounsfield units, vessel remodeling, and the napkin ring sign, as well as spotty calcifications, are associated with a high risk of acute coronary syndrome. Now, these high-risk plaque features can be seen on CT, as is shown here with the low attenuation plaque, as well as positive remodeling with vessel expansion, and the spotty calcifications, which can sometimes be seen in the vessels, and of course, the napkin ring sign. So what does this all mean? So this means that we really have to move the needle from looking at obstructive coronary artery disease to looking at early coronary artery disease subclinically, in addition to providing an opportunity for diagnosing these patients. This also provides an opportunity for implementing preventative strategies early to improve these patients' outcomes. And decreasing the overall plaque burden in our patients will decrease the risk of acute myocardial infarction, sudden cardiac death due to plaque rupture. Therefore, we need to move forward thinking from looking at non-obstructive disease as being completely benign, because it's really not entirely so. So with the chest pain guidelines, the attempt was to move or focus from looking just for obstructive disease to looking for the whole pathway from non-obstructive coronary artery disease right through to obstructive disease, and really identifying these patients earlier so that we can implement strategies to prevent their acute events. Now, how does this apply to is this relative to nuclear imaging? So it's interesting that the frequency of inducible myocardial ischemia on cardiac stress testing has actually decreased over the last few decades. And this is due to our very strong work in preventative cardiology, both primary and secondary prevention. And this was published in an article led by Dr. Henslova and Dr. Leidenthal in the JNC in 2020. A study was also published by the prominent investigators that have suggested that the Diamond Forrester classification system may overestimate risk of obstructive CAD in contemporary practice, with more than a quarter of these patients with stable chest pain being referred for non-invasive testing actually having normal coronary arteries and no long-term events. And then over the past 2 decades, the annual rate of all cardiac diagnostic testing have decreased and plateaued, and the use of SPECT have seen the same trend. Now, while the utilization of SPECT has decreased over this time period, the use of PET have been increasing, but there still remains a deficit and a wide gap between availability of SPECT over PET. Now, globally, according to the data that's available with IAEA, looked at over 134 countries, that out of the 195 countries that were surveyed, 134 of these countries had nuclear medicine facilities. And in these facilities, there are over 25,000 SPECT cameras, but there's a heterogeneous global distribution of these cameras in terms of the age of these cameras, the quality of these cameras, and also the availability of PET is still very, very limited. And in a study that was published back in 2021, also looked at that the global availability of PET is still quite low, in the realm of 5.9%. So most of our labs, both in the US and globally, still rely on SPECT for imaging our patients. And we know that there are challenges with SPECT. There's decreased specificity relative to artifacts due to soft tissue attenuation, and also decreased sensitivity looking at multivessel disease and left main disease. With balanced ischemia, of course, with PET and myocardial blood flow, you do not have that challenge, but of course with SPECT, there remains that challenge. Also with SPECT imaging, looking at just your plain SPECT camera without hybrid capabilities, you do not have the ability to image the full spectrum of coronary artery disease. And of course, there is the risk of radiation exposure. The advantage of SPECT is, of course, it's widely available. It's less costly. Most of us are familiar with the kinetics and the technology of the cameras. And this, of course, with nuclear imaging, can be used in patients, even those with end-stage renal disease and liver dysfunction. So some of the solutions that have been available lately with the latest technology is the use of hybrid SPECT systems with SPECT-CT. That helps us, as we'll see in later slides, to improve our accuracy for identifying these patients, and also to look, as we had discussed earlier, the full spectrum of the disease, looking at coronary calcification, and then also looking at perfusion. To position stress acquisition, so if you're in a lab that you do not have the latest hybrid systems or attenuation correction software, you can actually acquire your stress both supine and prone as a part of a 2-position stress acquisition to decrease the degree of artifacts and to decrease your false positive reads. Of course, on the horizon, as we'll discuss a little bit later, there is a concept of looking at myocardial blood flow with SPECT. It's not the standard, of course, but myocardial blood flow ideally should be done with PET, but there's some labs that are looking at using SPECT to look at blood flow And there are some promising results in that area. So there are four main areas where we can improve SPECT. As we had discussed, there's a modernization of software using with wide beam reconstruction and iterative reconstruction. This helps in noise reduction, and this also improves the study quality. And also there's a modernization of the hardware, changing out your gamma cameras with the solid state CCT cameras, also having a hybrid systems with the SPECT-CT. And many of these newer cameras allow you to only have the need to use a very low dose of the radio tracer, and therefore decrease radiation exposure to our patients. And as I had discussed earlier, there's dynamic SPECT imaging that looks at blood flow assessment. I think in 2024, we should all be doing some form of attenuation compensation, either, as I mentioned, two-position stress acquisition or using attenuation correction, and of course, adjunctive use of calcium scoring with your hybrid systems. Now, with the reconstruction software, with the newer systems, the iterative reconstruction actually helps to improve the quality of the study. It decreases the artifacts, especially with a ramp filter artifact, as seen in the older filter back projection processed images. That's all avoided with the newer software with iterative reconstruction. You also have resolution depth recovery, which improves the spatial resolution for the deeper structures within the chest. And then there's also scatter correction, which decreases and causes less artifacts that we would tend to have from Compton scatter. And this is just an example of the older systems with a filter back projection, where you have a very high uptake in the hepatobiliary system. And what tends to happen with the older software is that you would have an artifact in the inferior, in this case, inferior lateral wall, giving you an impression of a perfusion defect when that is in fact not the case. Now, with the neo-iterative reconstruction, you do not have the issue with filtered back projection. And as you can see, that inferior lateral wall is completely normally perfused. Even looking at the quality of the newer software with wide beam reconstruction, you can see that even with half-time imaging, you're getting a much better image quality compared to full-time imaging. And this can be very useful, especially if you're imaging older patients who may have musculoskeletal limitations. They may not be able to lay still for a long time. You can actually shorten your acquisition to allow a shorter scan time, less risk of motion artifact, and you, of course, the image quality is still preserved, if not better than the older software. With the modernization of the hardware, there's the use of the solid state CCT cameras that has a much higher sensitivity. And because of that higher sensitivity, you can use a very low radiotracer dose, and you can even get your radiation exposure to less than 5, and in some cases less than 3 millisieverts. You also have a very short scan time for these cameras as well. So again, it's more practical. You can do more scans in your lab and really improve your workflow. And with the hybrid systems, I know some of these solid state cameras are coming out with also the CT components, so you can actually have the solid state CCT in addition to the CT aspect of it, and have a full assessment of the patient, looking at both subclinical, CAD, and perfusion. And this is just going through the sensitivity. We can see with the conventional SPECT camera compared to the hybrid CCT, so the hybrid CCT camera compared to the gamma camera. And you can see that you have a much higher sensitivity with the CCT cameras compared to the older systems. Of course, the older gamma cameras dealt with more indirect conversion, where you had to have the photomultiplier tubes. And of course, because of that, you have much lower sensitivity with those systems. Now, what's really out there in terms of the market for these CCT cameras, you have the, with the solid state systems, you have the high sensitivity parallel collimator, as is used in the D-SPECT camera system, where the collimators are square with a parallel hole and each are coupled to a single detector. Then you also have the multi-hole collimator design that's used in the Discovery camera system. And then you also have the collimator design with a newer general purpose collimator in the Veriton camera systems that uses three-dimensional body contouring. So these are the three main ones that are on the market. And just as I had mentioned, with the count sensitivity with the solid state, it has at least 8 times higher sensitivity compared to the older gamma cameras. And the count sensitivity is similar to the older PET systems with two-dimensional PET, is somewhat close to that. Of course, these days with 3D PET, that's where you really get your highest count sensitivity. So I'm just going to touch a little bit on myocardial blood flow quantification with SPECT. So as I had mentioned, this is not the gold standard, but if there's some labs that are looking into it, and that's something that is on the horizon. And as I had mentioned, the reason that you were able to do this with the solid state SPECT is that you have an improved count sensitivity, and with dynamic SPECT, you can actually assess blood flow. And this was actually seen on a study that was published in approximately 3 or 4 years ago, where they looked at approximately 25 patients who underwent rubidium PET compared to CZT SPECT, and they assessed blood flow on both systems. And we can see here that there was some decent accuracy. There was an accuracy of at least 75% of correlation with blood flow with the CZT system compared to the PET system. So there are some promising areas in that aspect. So there's some challenges and with myocardial blood flow with CZT SPECT, and I had gone through this in an editorial that I had published earlier last year, looking at the challenges. And I think one of the main challenges is that there's a lower extraction fraction for technetium-99 radiotracers at higher flow rates compared to those used in the cardiac PET studies. There's decreased spatial resolution of the solid state CZT camera compared with cardiac PET. As I had shown you, 3D cardiac PET has a much higher sensitivity. And most of the CZT cameras still do lack some attenuation correction, although the latest cameras on the market, there are some cameras that use AI for attenuation correction, and there's some that will have the CT component for that. But for the most part, there's still some area of need for improvement in that space. And also, dynamic SPECT processing is very reliant on manually correct information, which can be a source of error and can also decrease your reproducibility. And then finally, the heterogeneity of CZT SPECT-based myocardial blood flow volumes leads to a lot of variation and it all depends on your radiotracer selection, the injected doses, the reconstruction algorithm, and also the kinetic models. So these are the 4 challenges that remain, and I think hopefully with improvement in technology, these areas can be improved. So this was actually looked at by a group that was led by Dr. DeCarli and colleagues, and they looked at how can we reproduce accuracy and reproducibility of blood flow quantification with SPECT in patients with known or suspected CAD. And this was published approximately 2 years ago in 2022. And what they looked at was the use of spline fitting to improve the correlation with SPECT compared to PET. And what they found was that with myocardial blood flow quantification and flow reserve using the CZT SPECT cameras with a spatiotemporal spline fitting models, that this actually improved the correlation with ammonia PET and had also improved the test and retest reproducibility. So they had recommended that if labs are using blood flow assessment, that the use of these spatiotemporal spline fitting models may represent an important step forward to improve accuracy and standardization of flow estimation. So looking at compensation, 2-position compensation, so that's another area in which we can improve accuracy. And this was a case that was done in my lab a few years ago, possibly about 5 years ago. And I think this really brings out the importance of doing 2-position imaging, where, as we can see, the initial stress supine images shows this medium-sized area of moderate photon reduction in the anterior and anterior septal wall. And it looks reversible when comparing to the rest images. But then with the stress prone, you can see that defect completely resolves, which indicates that, that this study is in fact normal. And you can just imagine if you did not have the attenuation correction, you'd be calling many of these studies falsely positive and really decreasing the quality of your interpretation in your lab. Now, for those who have the SPECT-CT hybrid systems, there are still potential artifacts that can be seen, especially with misregistration, and this is an example of that, where you can see the perfusion image as is shown here and relative to the CT projection of the heart. And then you can see here on the left that there's misregistration, right, where there's some it's basically not fully overlying the heart, and with that it's you can see that there's a lateral wall defect here that is in fact an artifact, because when you correct that and you completely have the perfusion laying over the heart as it should be, you can see that defect is completely gone. So it's very, very important that when you're doing hybrid imaging that you're looking and to make sure that you're avoiding misregistration artifacts, because that can also be a source of error. Now, use of calcium scoring has also been studied with SPECT-CT hybrid systems, and this was actually published many years ago in 2015, looking at over 1,000 patients. And what they had shown was that with the use of calcium scoring, that this actually had improved the accuracy and also visual assessment for these patients, and also improved the ability to assess their prognosis over time because of the added value of the calcium score. And this was a case that we did in our lab. It was a 67-year-old female who had risk factors of diabetes, high blood pressure, and hyperlipidemia, who presented to us with a year history of having decreased functional capacity due to distal exertion, as well as sharp chest pain. And you can see here that on the SPECT, she had this inferior defect that had mild photon reduction that was somewhat reversible. And then on the corrected images, that defect completely resolved. However, you have to look at everything when you're doing your studies. She had only walked for 3.5 minutes. She had had to stop because of chest pain, and she also had significant changes on her EKG. So obviously this patient is still not out of the woods. Unfortunately, she had a calcium score with it, and we can see that her calcium score was over 1,000, involving all of the major epicardial vessels. So she went on to have a cardiac catheterization done, and we can see that she had critical osteo left main disease, and same for the right coronary artery. So this is a classic example of balanced ischemia, and without the added value of the clinical response to exercise and the calcium score, you can see that this patient was a very high risk patient, and she went on to have 4-vessel bypass surgery and did well thereafter. So hybrid imaging is a very important part, and that's an area that FASNC has focused on. And there was a paper that was published in 2022 led by Dr. Moaz Almala, and he looked at the group looked at guidelines for the use of CT and hybrid SPECT systems, and I'll highly encourage the audience to take a look at that article. And the reason for this is that the use of calcium assessment is very important to predict both long and short-term cardiac events. And even in the setting of normal SPECT, you can see that these patients who have high calcium scoring are still not out of the woods and have an increased risk of cardiac events. So I'm not going to go too much in PET, because I know that Dr. Bourque is going to speak about that. But there are several advantages of PET over SPECT. There's greater accuracy, also greater prognostic assessment, shorter scan time, also allows for myocardial blood flow quantification and flow reserve. And with the hybrid PET systems, you can also look at calcium for subclinical coronary artery disease. And the accuracy of PET has been known for over a decade. And this was actually published in 2015 that showed that PET had a much higher accuracy over SPECT. And this is just showing that, where you have the ROC curves, and you can see here that PET has a much higher AUC compared to SPECT. And even looking at more contemporary studies, looking at CT, SPECT, PET, hybrid systems, you can see here that PET had a very high accuracy relative to SPECT and even relative to CT as well. The contractile reserve is also very important to look at when you're doing PET. So, of course, because you're imaging the patient and you're doing the stress test essentially while the patient is under the camera, that EF that you're seeing, especially post, the stress portion of the study, really that EF should be higher than what is seen at rest. And if you do not have that increase in EF, then that patient, there's a suggestion that there's a lack of contractile reserve, and those patients actually fare worse when it comes to cardiac events, as is shown in this paper, where patients who had no contractile reserve basically had a higher event rate both for cardiac events and all-cause deaths. Coronary flow reserve is also very important for PET. It's very vital, not just looking for obstructive coronary artery disease, but also coronary macrovascular dysfunction. Because coronary flow reserve, especially when it's abnormal, have been associated with increased risk, both major adverse cardiac events and mortality. And flow reserve also improves accuracy in terms of interpretation for PET and looking for triple vessel or left main disease. And this is what was actually studied and was published in 2020 that looked at event-free survival in patients with flow reserve, with abnormal flow reserve compared to normal flow reserve. And even when also with the use of perfusion, you can see that these patients, especially for those who had a very abnormal flow reserve and a very abnormal perfusion, that those patients had a much higher percent of major adverse cardiac events. And the reason that coronary macrovascular dysfunction is important is because it has been associated with poor outcomes, and it affects predominantly females compared to males. And even in the setting of normal coronaries on cardiac catheterization, these patients, especially with coronary macrovascular dysfunction, are oftentimes very symptomatic. They're going from different doctors, ER visits, multiple ER visits, and I think being able to diagnose these patients and to be able to effectively treat them is important because, it increases the cost of care, especially when these patients are going to multiple providers to reach this diagnosis. So there's still challenges that need to be met with nuclear cardiology. There's a need for modernization of nuclear labs throughout the US and globally. There's also a greater need for accessibility to cardiac PET. I think we all see the advantages of PET, and I think being able to have accessibility both in the US and globally is important. There's a need to use hybrid imaging for imaging both SPECT-CT and PET-CT so that we can see not just perfusion, but also calcium scoring to see if there's any subclinical CAD. There's also need to use to study the utilization of nuclear imaging to assess both effectiveness and response to therapy, and that's where molecular imaging may be useful. So I think nuclear medicine has come to a fork in the road with being a choice of whether being a diagnostic lesion detection technique or whether we are going to join the revolution in precision medicine and really characterizing tumor and physiology as well as biology to help in effectively identifying high-risk patients and to also, treat these patients earlier to improve their outcomes. So I think looking just beyond the perfusion is important. So I think how does this, what are the implications for nuclear lab accreditation? I think, there is a need for greater rigor in terms of ensuring test accuracy for myocardial perfusion imaging by minimizing attenuation and false positive tests. Also, there's a greater need to use a hybrid MPI imaging. I have shown you the value of that, improving accuracy. But of course, there's some physicians who may not be certified in CT. So how can we overcome these challenges, getting both the physicians and the technologists certified in CT to also be able to practice that side of the care. Newer CCT cameras have artificial intelligence looking at how does this impact or diagnostic ability, also even a prognostic assessment of our patients, and who is going to provide this oversight for AI, I think is also very important. So in summary, there's the landscape of CAD and perfusion imaging has changed. And I think we are moving now beyond just looking for abnormal perfusion, but looking beyond that to see what's the entire risk profile for the patient that's presenting to us in the lab. There's a greater need for accessibility for the latest technology, both within the US and globally. Definitely a greater need for PET because we can see that PET has several advantages over SPECT. And I think the future of nuclear medicine, we need to move to precision guided care and really modernizing our labs. And this will, of course, have implications for the IAC. and Nancy and her team. And with that, I'd like to thank you very much for your attention. And I'm happy to hand things over to Dr. Jamie Bourque, who is giving his talk. Thank you.
Hi, everyone. Sorry for the long pause there. I was talking very eloquently on mute. Renee, thank you very much for the nice introduction, and I want to thank you for inviting me to speak, as well as to the IAC, to our colleagues on the CT board and our PET nuclear board. And my talk today will be on novel applications of cardiac PET, myocardial blood flow quantification, and evaluation of systemic inflammation, infection, and infiltration. And here is my disclosure. So a brief roadmap. So I want to first address myocardial blood flow applications in ischemic heart disease, and I will speak both about ramifications in obstructive CAD, but also our evaluation of microvascular dysfunction, as Dr. Bullock-Palmer had briefly touched upon in her presentation. And then we'll move into applications in systemic diseases that have cardiovascular manifestations, and we can talk about inflammation, cardiovascular infection, as well as amyloidosis. And my learning objectives will be for you to be able to understand the use of myocardial blood flow assessment in PET myocardial perfusion imaging, and for you to define the role of cardiac PET beyond myocardial perfusion imaging, including in inflammation and infection imaging. And we'll go ahead and start with a case. Ms. K is a 66-year-old female who has a history of hypertension and metabolic syndrome. She presents to general cardiology clinic with exertional chest pain. She does have a BMI of 33 and she's sedentary. She has multiple cardiac risk factors as listed. And a question could be, what are our next steps for her? So of note, additional info, she had a recent exercise SPECT perfusion imaging study during which she reached 6 METs of exercise capacity and had no ECG changes during the test. She had a borderline inferior defect. Unfortunately, attenuation correction was not performed in this study, and so this was really a borderline or equivocal study. Ultimately, because of her symptoms, she had invasive coronary angiography performed, and she had, perhaps not surprisingly, normal coronary arteries. So we'll come back to Ms. K, but cardiac PET has had a rapid growth in use that has been led or made possible by the expanding use for non-cardiovascular conditions. PET cameras are now increasingly available across the country and worldwide. And there's also been increased tracer availability. And this is to be even more the case when flurpiridaz comes on the market in the near future, extending reach to smaller centers. And so there's a growing use of cardiac PET, and then there are technical advantages that PET has. So it allows a comprehensive evaluation of not only perfusion, but also left ventricular function and absolute myocardial blood flow. If you look at this diagram to the right, you can see that there's a ring detector that's around the patient. And when the positron emitter gives off the positron, it results in 2 511 kiloelectron volt photons that are given off 180 degrees apart from each other. And those can be measured by the ring detector as a coincidence event. This really helps us to not only reduce scatter issues, but also because of the fact that the ring is all the way around the patient, we can have much better temporal resolution, and there's high spatial resolution with PET. There's intrinsic attenuation correction, which is not only from the coincidence detection, but also due to the pairing with CT. And there's ultimately high tracer sensitivity due to the fact that these photons are high energy. And this allows us to use this tool with increasing effectiveness in patients who have higher BMIs. And so all of these advantages lead to greater diagnostic accuracy. If you look at this seminal paper by Tim Bateman et al. From 2006, you can see that there's a similar, if not slightly increased sensitivity, but a statistical significant increase in specificity, as well as a marked increase in diagnostic accuracy with PET over SPECT. One of the most valuable pieces of information that we can get from PET is the absolute myocardial blood flow. And you can see here that we can get stress myocardial blood flow. We can then divide that by rest myocardial blood flow, and that gives us a marker of the augmentation in blood flow from rest to stress, and that can be denoted as the coronary flow reserve or the myocardial flow reserve or the myocardial perfusion reserve, a lot of different terms that are used to represent roughly the same thing. And you can see here that if you have a patient, both of these patients here have normal resting perfusion imaging, or relative perfusion imaging. But you can see the one on the left has a blood flow that's normal at rest that is augmented 3.3-fold to 2.3 mil per min per gram with stress. And so this is a normal response and normal coronary flow reserve or myocardial flow reserve, whereas the patient on the right starts out with a similar normal resting perfusion, absolute myocardial blood flow, but has very little augmentation with stress, a flow reserve that's markedly abnormal. And this is either associated with obstructive epicardial coronary disease that in this case would be diffuse, so would be 3-vessel, or it can be associated with disease in the microvasculature. So the CFR, MFR, MPR interrogates the entire vasculature, not only at the epicardial or highways, but also the city street level, the microcirculation. And we know that the MPR, MFR, CFR has enormous diagnostic and prognostic value. If you look at the diagram or the graph on the left, you can see that as the flow reserve decreases, and in particular goes below 2.5 and 2, you can see there's a marked increase in the probability of 3-vessel disease. So the balanced ischemia that we worry about with SPECT, we can typically identify using PET imaging by our absolute myocardial blood flow assessment. And then there's really powerful risk reclassification in the prognosis with MFR. So if we see the pre-MPR, CFR, MFR risk, and in this large study of 2,700 patients who had rest stress PET MPI and a 1.4-year mean follow-up looking at cardiac death by Venk Murthy and the team when he was at Brigham, you can see that if we classify that pre-CFR risk using all of the other information available into low, intermediate, and high risk, when we then add absolute myocardial blood flow, CFR, you can see that there's a substantial reclassification of risk, especially in this intermediate group. And you can see that those reclassified risk groups have a stepwise marked and significant differential annualized cardiac mortality. So this is a very powerful prognostic tool. It can also be useful in coronary revascularization. So Viviani Tecchetti, also from the Brigham group, showed that if you have a normal CFR, that there was no difference in annualized cardiac events in this smaller population, but still a robust number, with CABG versus PCI versus medical therapy. However, when you had a low CFR, there was a marked improvement with revascularization, in particular with CABG. And ultimately, all of these advantages of PET with myocardial blood flow, the LVEF reserve that Dr. Bullock-Palmer had mentioned earlier, as well as all the technical advantages and the increased diagnostic accuracy, have led to a superior comparative effectiveness when PET is compared against other techniques, in particular compared with SPECT. Here you can see SPECT in the green, PET in the red. It had the highest diagnostic accuracy. And then in the Pacific trial, where they did a per patient analysis, you can see that PET did best even when compared with both CTA and CT-FFR. So this was has been shown to be a very effective tool for the evaluation of ischemic heart disease. So that value extends beyond our global population into special populations. So here you can look at patients with diabetes mellitus, a group that we know is very high risk. And so if we take our typical annualized cardiac mortality in a group that doesn't have known CAD, does not have diabetes, has normal perfusion, the risk is about 0.5% per year. And it turns out that even if you have diabetes, but you have a normal coronary flow reserve, then you have no increase in that event rate. But when you drop the coronary flow reserve less than 1.6, you can see that there's a marked increased risk of events from 0.3% up to 2.8%. And that number is not any different from those patients who had known CAD, even who did not have diabetes, and is actually similar to those who had CAD and diabetes. So this has very powerful prognostic value in the diabetic population as well. I'm not showing the data, but CKD in addition. So how about for patients who don't have epicardial coronary disease, but have microvascular disease? We know that ischemia with no obstructive epicardial CAD, or INOCA, ANOCA, there are a lot of acronyms that are used to describe this, is highly prevalent. We know that MPI is negative in approximately 90% of patients, and cath is negative in those who even get to cath, still in 65%. And despite the fact that obstructive epicardial coronary disease, INOCA has very poor quality of life. So we did a study where we looked at quality of life scores from populations who had had a recent acute MI, elective PCI, or known stable CAD. And then we measured the quality of life of a population with INOCA at our lab at University of Virginia. You can see that there was decreased, lower scores, worse quality of life using the Seattle Angina Questionnaire in patients who compared to even these other fairly morbid populations. We also know that INOCA has a fairly significant incidence of coronary microvascular dysfunction in the realm of 45 to 65%. We know in CMD that there's that CMD has diagnostic and prognostic value in INOCA. So there are numerous causes of chest pain in INOCA, non-cardiac causes, pulmonary, gastrointestinal, musculoskeletal, et cetera. And then there are cardiac ischemic and non-ischemic etiologies, everything from inappropriate pain perception and pericardial issues to the variety of microvascular conditions and issues, including smooth muscle dysfunction, endothelial dysfunction, coronary spasm. And so PET and absolute myocardial blood flow assessment of CMD can help provide a diagnostic answer to the cause of a patient's symptoms, which incidentally significantly improves their quality of life when they have an answer, data that I'm not showing. But also you can see here that there's a prognostic significance in patients who have normal relative perfusion, but a high CFR. You can see this was a study using N13 ammonia, that there's a marked increase in MACE and cardiac death. Why is it important? So prognosis and diagnosis, but also therapeutic changes. So the CORE-MICA trial looked at 391 patients without obstructive coronary disease and randomized patients to either stratified medical therapy based on their invasive CFR and vasoreactivity testing versus usual care. And there was improved quality of life in the group that had the stratified medical therapy. So you can see here, if you look on the right, that the use of beta blockers, RAS intervention, and lifestyle changes in microvascular angina, calcium channel blockers, nitrates, lifestyle changes in vasospastic angina, and not providing any cardiac therapy in patients with non-cardiac chest pain led to favorable changes in angina summary scores, limitations and stability, angina frequency, treatment satisfaction, as well as quality of life. So going back to Ms. K, she had been having daily chest pain with marked functional impairment. She was no longer able to watch her granddaughters. And so she underwent additional testing with an N13 ammonia PET myocardial perfusion imaging study. If you look at the relative perfusion imaging on the right, you can see that there are no marked perfusion abnormalities visible. But when we look on the left, you can see the absolute myocardial blood flow numbers here at stress. These numbers should be above 2, and they're significantly reduced in the 1.4 range. And then the coronary flow reserve, which should be greater than 2 to 2.5, was 1.58. So she was diagnosed with coronary microvascular dysfunction. And she was ultimately given aggressive risk factor management. So she had had no evidence of obstructive coronary disease on her cath. So in the past, she might have been told that this was not her heart and she should go find another cause of her symptoms, which would likely not have been effective. But instead, she was given aggressive risk factor management, a baby aspirin, high-intensity statin, aggressive blood pressure control. She was given anti-anginal medications, and she was given an exercise prescription and entered a steps competition with her friends. She had improved quality of life with decreased chest pain frequency and intensity, improved mood, and she ultimately was babysitting her granddaughters again. So now shifting gears and talking about cardiovascular manifestations of systemic disease, we know that there are multiple complex systemic diseases that have potential cardiovascular involvement, and that includes infiltrative disease, inflammatory disease processes, as well as infection. In these different disease states, multimodality imaging is key. But nuclear imaging can be very helpful to diagnose not only the presence and degree of cardiovascular involvement, but to inform prognosis and to guide treatment, as well as to assess treatment response. And you can see here on the right, we put together a series rationale methodology for a new series that's going to be coming out from ASNC called ASNC Imaging Indications. And I'm very excited to report that our first one in cardiovascular infection, I got the proofs back a couple days ago. So it's going to be hot on the presses soon. So be sure to look out for that. So Mr. R is case number 2. He's a 55-year-old male who was admitted with a CHF exacerbation. On his EKG, he had ventricular tachycardia and his cath showed no obstructive CAD, but his echoes showed a marked left ventricular dysfunction with an EF of 20 to 25% and segmental wall motion abnormalities that were present that were not in a coronary distribution. So there was suspicion that he might have cardiac sarcoidosis. So what are our next steps in his care? So we know that sarcoid is a multi-system inflammatory granulomatous disease. 2 to 27% have cardiac involvement. And unfortunately, although it's a mainstay first imaging study, echo is nonspecific and insensitive for early changes. Likewise, CMR provides excellent scar mapping and is very good at identifying patients who have had prior disease bouts or significant ongoing inflammation, but it doesn't necessarily assess active disease, whereas PET-CT with F18 FDG use can actually assess active inflammation. So the inflammatory cells utilize glucose, so we can directly image the inflammatory cells that are present in the myocardium. And then we can use our high spatial resolution perfusion imaging to assess myocardial damage. There's prognostic value with PET-CT, and it can guide therapy and help with assessing response to therapy. So if you look at this figure on the right that Ron Blankstein and colleagues put together, you can see that there are a variety of patterns that can help you identify what's going on. So patients with intact perfusion and no FDG are normal. If you have diffuse FDG uptake, that is probably that you were unable to suppress the myocardium. There are robust ways to figure that out these days, but they may just need repeat imaging. And you can see that it is possible to have isolated FDG with no perfusion abnormalities, which may represent early disease or a normal variant, but you may also have a isolated non-coronary distribution perfusion defect with no FDG, and that may represent old disease. But what in particular we're looking for is patients who have perfusion defects with matching or non-matching, as the case may be, areas of FDG uptake, and this typically represents or is indicative of active inflammation. And we know that FDG PET-CT has very high diagnostic accuracy with a pooled sensitivity of 89% and specificity of 78%, and has prognostic value where there's a stepwise increased risk of death or ventricular tachycardia as you add abnormal perfusion or FDG here in blue, or you add both of them in red. So for Mr. R, he had an FDG N13 ammonia PET-CT performed. And if you look on the right here, you can see the perfusion shows a perfusion defect in the inferior and septal walls, and that's present all the way from the apex all the way out to the base. And then in the FDG images which are on the top, you can see that there's very robust FDG uptake in a matching distribution where the perfusion defect is. So this is indicative of a substantial amount of systemic inflammation. He was started on prednisone and transitioned to mycophenolate mofetil. He was also started on aggressive heart failure goal-directed medical therapy, and he had repeat imaging at 3 months, and you can see that there's been marked suppression and resolution of his active inflammation. So this is very helpful in guiding therapy to determine whether you've actively suppressed the inflammation and so effectiveness of therapy, and also potentially what the next steps might be. So moving beyond sarcoid, other disease processes such as large vessel vasculitis, there has been early data looking at FDG PET-CT in large vessel vasculitis can help identify a vascular cause in patients with unexplained fevers and inflammation. It has utility in not only diagnosis, but also prognosis and serial treatment monitoring in large vessel vasculitis. So we do have an ASNC I-squared consensus statement that is planned for large vessel vasculitis. Here on the right, you can see sort of the lining of the aorta here. We can see it even more prominently here and coming down the descending aorta. And you can see, looking at prognosis, that patients have a higher mortality when they have FDG uptake versus those who do not. So this has prognostic significance as well. So moving beyond inflammatory into cardiovascular infectious etiologies, there is a prominent role for PET-CT in infective endocarditis as well as in implanted device infections. So we know that the mainstay of imaging cardiovascular infection remains transthoracic and transesophageal echo, but sometimes you need more information than that, and PET-CT is an important ancillary tool that can increase our diagnostic accuracy. So particularly in prosthetic valve endocarditis, it provides more definitive diagnoses. It's been shown to provide a conclusive result in 97+% of cases, increased from just 70% with echo alone, and allows an earlier diagnosis possible than just used with echo. It's also particularly able to identify manifestations outside the heart, so extracardiac spread as well as embolic events. We know in native valve endocarditis, there's a reduced sensitivity when used alone, partially because of valve motion and the fact that a lot of vegetations on native valves are small, but it does increase the diagnoses when added to the modified Duke criteria. There's growing data in this area and increasingly standardization of protocols. So if you look for extracardiac foci of infection, PET-CT has a sensitivity of 87 to 100% and a specificity of 80% for embolic events. You can see here pulmonary embolic event, one in the spleen, one in the spine. And then you can look for extracardiac or paravalvular extension, and there's even some early preliminary data looking at pre and post therapy to assess effectiveness of antimicrobial therapy. this is still an area under evaluation. PET-CT can help detect unusual sites of infective endocarditis, including the descending aorta, mural endocarditis, tuberculomas, as well as in pulmonary conduits. And we know in CID infections, PET-CT can help differentiate superficial versus deep pocket involvement, can help identify intravascular involvement in bacteremia in patients who have indeterminate other imaging, and can evaluate mobile masses seen on TEE, TTE, as well as evaluating FUOs. You can see here someone with clear involvement of the pocket, and then you can see lead involvement as the lead is coming down to the level of the heart. So ultimately in CID infection, there's high diagnostic accuracy with an area under the curve of 93%. It's very high sensitivity and specificity for differentiating superficial versus deep pocket infections, a little bit lower sensitivity specificity to identify lead involvement, but certainly can be helpful. And we know that LVAD infections, which typically are not able to be well evaluated by echo, can be evaluated very well by PET-CT, and you can not only look at the inflow and outflow cannulas, but also the pump itself, as well as the drive line, and with high diagnostic accuracy and prognostic significance. And the latest ESC guidelines have just come out and have incorporated PET-CT and white blood cell imaging actually as well in the guidelines with a fairly prominent role. And just to remind you to look out for our ASNC I² multi-societal clinical indications document that will be coming out in the next month or two. And then ultimately, amyloid imaging, infiltrative disease can be possible with multiple tracers. Several tracers under study: florbetapir, florbetaben, flutamidamol, C11, Pittsburgh compound B, and others. They allow non-invasive assessment of AL cardiac amyloidosis as well as ATTR cardiac amyloidosis, and a better ability to quantitate, and PET quantitation, more robust quantitation, can allow earlier diagnosis when a lot of the therapies can be most effective, as well as potentially allow treatment monitoring. So in summary, absolute myocardial blood flow is playing an increasingly important role in the evaluation of both epicardial ischemic heart disease and INOCA, and there are multiple exciting applications of cardiovascular PET imaging in inflammatory, infectious, and infiltrative systemic diseases that not only allow improved diagnosis, refined prognosis, as well as to potentially guide treatment and assess response to therapy. And with that, I will finish up. Thank you very much.
Thank you, Dr. Bourque. At this time, we're going to take a couple minutes to answer a few questions. We know we're over a little bit about time, but we're going to present a couple. For that, I'd like to introduce Maria Costello, Lead Clinical Director and Director of Accreditation for the Nuclear PET Division at the IAC, who will be presenting the questions. Maria, would you like to get us started?
Sure. Thank you, Nancy. And thank you, Dr. Bourque and Dr. Bullock-Palmer for great presentations. The first question, do you have any tips or advice on performing PYP scans on a CZT scanner? And either one of you can, either Dr. Bourque or Dr. Bullock-Palmer can answer.
I'll answer, and then Paul or Jamie can supplement, because I'm not sure if you're doing PYP on the solid state cameras. We have our solid state. We got this a year ago, and we still do our PYP scans on the gamma camera. Reason being, with the newer systems, the CZT system, you do not have a planar image, right? So it with our DSPECT, it creates a planar image through AI. So it's a pseudo planar image. So we've sort of feel more confident doing the amyloid imaging on the older cameras. That being said, the latest guidelines recommend that we should be doing SPECT on all of our amyloid studies because of the false positives using planar only. So we use SPECTs for all of our amyloid patients. If you do not have the gamma camera, you can still do it on a CZT camera. There is, especially if you have the hybrid CZT camera, you can actually correct, because if you see uptake and you're doing your SPECT and you see uptake in the area of the heart, you can actually make sure that that's in the myocardium if you have the overlay of the CT. So and you can also quantify the amount of technetium that's been taken up in the myocardium, and you can quantify it with dynamic imaging with the CZT. So there are benefits to using the CZT camera. I would not rely on the pseudo planar to interpret those studies if you're using the CZT cameras. So I don't know, Jamie, do you have any thoughts on that?
So I agree with everything you've said. So there certainly is good data to support imaging PYP on CZT cameras. I would say that we are now at the point where we're thinking of actually dropping our planar imaging, partially because our readers, it's been very hard to wean them off of the heart to contralateral lung ratio. And really, the most effective way for evaluation increasingly is shown to be looking at the SPECT imaging. And increasingly, I think that this is an important role, as Dr. Bullock-Palmer was saying, for the use of CT. We're finding that increasingly, as the populations have been broadened who are getting imaging, including a lot of patients pre-TAVR, that we're getting a lot of sort of borderline grade 1 cases, and it's hard to know where the myocardium is. So I think even more important than CZT versus not is, are you using SPECT and are you using CT?
Okay, thank you. I think at this point, because we are running over almost by 5 minutes, we're going to wrap up the session. But anyone who submitted questions, we will get a copy of them and we will get the answers to you. And thank you for joining us. And I will just pass it back to Nancy.
Thanks, Maria. So just again, thank you everyone for joining our webinar, and especially thank you to Dr. Bullock-Palmer and Dr. Bourque for their fantastic presentations. Once again, thank you for joining us, and we appreciate your participation.